Good morning. My name is Linda Rothstein. Welcome to the conference session titled Aplastic Anemia. Thank you for joining us. As we get started, AAMDF, I'm not used to saying all the initials, AAMDSIF would like to recognize the generosity of the corporate sponsors, diamond level sponsors, Alexion, Novartis, gold level sponsor, Apellis, and Genentech, and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. When asking questions, please wait for the microphone so everyone will hear the question you're asking. Please do not share private health information on your question. The speakers cannot answer any specific questions related to your health care. Today's specialist, Dr. Daria Babushok, is a physician scientist and assistant professor of the University of Pennsylvania. Her research and clinical interests focus on the development of acquired and inherited bone marrow failure, disease progression, malignant transformation, and improving treatment in patients with bone marrow failure. I had reached out to Lee Clark, patient educator, for a recommendation for a doctor who I could contact with expertise in aplastic, which I've had since November 2010, and a rare hereditary blood disorder that I've had all my life. She gave me Dr. Daria Babushok's name. My first meeting with Dr. Babushok was almost a year ago. From my first meeting moving forward until today, I'm thankful for finding her. Her understanding patient manner, ready to answer my questions, discuss treatment options with me in a calm and give and take, providing me with the assurance that we are working together to provide me with the best treatment options. In the masked world that I've been living with, her expressive eyes and gentle tone of voice have guided me on my journey since then. Thank you, Dr. Babushok. This is my first time she's seeing me full face and I'm seeing her full face. With that being said, it is my pleasure to welcome Dr. Babushok.
Thank you, Linda, so much. And thank you to Lee and Alice and AAMDS for organizing this, this wonderful meeting and for having us here hosted from University of Pennsylvania and the Children's Hospital of Philadelphia. So we have a wonderful program today. So today I'll talk about the aplastic anemia, the journey, or how Ellen expressed how to eat an elephant one bite at a time. How do we tackle this disease and how do we experience it from the diagnosis through treatment and all of the follow-up adventures. So I have no disclosures. Topics that I will cover today. So I will very briefly discuss, I know if some of you have been here, were here yesterday, there were some talks about the basics. So blood counts, bone marrow. I'll mention very briefly, just to be sure that we are using the same terms, how to diagnose aplastic anemia, what causes it, what triggers it, severities, because this really impacts how do we approach it philosophically. The cure cannot be worse than the disease, moderate, severe, very severe. And then talk about the main treatment options, so transplant, immunosuppressive therapy, and what is new on the horizon. I'll just start right now just to discuss blood, bone marrow basics, what is bone marrow failure, what causes that, and how do we diagnose it. So first, this is a diagram you may have seen before, but essentially what do we talk about when we say blood? So blood has several components. We can see here in this tube of blood, when the blood is taken from your body and it settles in the tube, at the top we have plasma. That's the liquid part of the blood. And so in that part, for example, when you hear that your doctor is checking your liver tests or kidney tests or checking whether you responded to a vaccine or have lupus, so what they're doing is they're taking and trying to figure out from the proteins that are in that liquid part, whether we have antibodies, for example, autoantibodies or antibodies to viral infections and electrolytes and things like that. At the bottom of the blood tube, once it sits, we have the red blood cells. So that's when we talk about, for example, the hematocrit being, let's say, 40%. That's going to be how much of that blood is in that red cell compartment. And then we have the white blood cells. So the white blood cells are basically our immune cells. And on a CBC, right, so the complete blood count, when that white blood cell, WBC, is low, the first question in your hematologist's mind is what exactly, which component of that white blood cell is low? And we specifically think about neutrophils. And neutrophils are, or granulocytes, these are immune cells that are incredibly important for fighting off infection. So they're our first defenders. And essentially, the way I would describe it, let's say if you were gardening and you nicked yourself with a thorn and then you have pus. What is pus? Well, pus are these neutrophils that are coming to the site of infection to try to clear up these bacteria. And if you don't have those neutrophils, you're really at risk of infection. And there are sort of gradations of neutrophil count, but really less than 0.5, or sometimes we call it in different units, 500 would be considered critical. And so at that point, our body, those cells usually secrete substances that make fever. Patients may not be able to mount a fever. So you could have, for example, an infection that may go unnoticed for a little while, and then it can become severe. That's why there are all of these things, and we can talk about, for example, precautions and various things your doctors may be discussing. So ANC is the absolute neutrophil count. And then somebody who has low neutrophil count would be called neutropenic and would have the neutropenic precautions, for example. And then, oh, very good. And then the other type of cell that is also very important and critical to understanding aplastic anemia are the lymphocytes. So lymphocytes are very important for fighting off infections, for example, colds, flus, being sure that we don't have infections with just regular molds, for example, or with gardening. And so those lymphocytes also can become abnormal, and in aplastic anemia, they decide to attack your own body. And so they are sort of the bad actors in this disease. Now, second part that I'll mention, so red blood cells, that's on your CBC is listed as RBC. We usually don't even mention, so it's reported on the report, but what matters here is the hemoglobin. So that is because the function of these red blood cells is to carry oxygen and deliver oxygen to all of the blood tissues. And it does it by carrying this protein called hemoglobin that binds oxygen. And so what matters here clinically when we see somebody is what is the hemoglobin level? If the hemoglobin is low, then we call this term anemia. And when people are anemic, you would be feeling tired, winded, short of breath, but it's amazing how our bodies can also adjust. So somebody may live, for example, for a very long time with a hemoglobin of 7, and if they're young, they may feel okay, while if you normally had a normal hemoglobin and your blood counts fell precipitously, you would feel it immediately. And then the other key parameter, perhaps really the most important in deciding the cause of the anemia, is the reticulocyte count. It's really quite critical because reticulocytes are the baby red blood cells. So if someone is coming in with a very low hemoglobin and I check the reticulocyte count and it's high, I know they may be losing blood. I know that they may have PNH or some other cause of destruction and that their bone marrow works okay. But if their hemoglobin is 7 and the baby red blood cells, the reticulocytes are low, it means the bone marrow is not making the blood. And then we have a production problem. And finally, the platelets. And so the term that we use for low platelet count would be thrombocytopenia. And these cells are helping us clot. And then if we have low platelet count, and that's really one of the presenting features of aplastic anemia, would be bleeding and bruising. All of these blood cells are made in the factory in our body, and that's inside of the bone marrow spaces. And we can see here on the left part of the slide, we have a picture, cross-section of the bone. So this would be, for example, a femur, so the long bone of the leg. And then we see here that in the ends of those bones, we have little spaces, sort of these spongy spaces, they're called niches. And it's sort of magical in a way. If you imagine somebody is getting a bone marrow transplant, that transplant is infused through our blood and the stem cells go and home in into those areas in the bone because they have lining with different cells. There are resident cells inside of the bone that secrete different substances. There's very close access to blood and growth factors. And so our stem cells that are infused during the stem cell transplant go and home in and set up shop, and then they start making all of the blood. And so really to know, once somebody's blood counts are low, to know what is going on, we have to do a bone marrow biopsy. And so you can see on the right side of the slide, I think many people in this room have experienced it. In adult medicine, we frequently have the bone marrow biopsy done under local anesthesia. It's also sometimes done now with guidance, more and more so, and with some sedation, usually, if it's a difficult procedure. But essentially what we do is we take a piece of the bone that shows the architecture plus the liquid part in order to assess the health of what is in the bone marrow. And as was discussed yesterday, for those of you who were able to be present at one of the evening lectures, our bone marrow, the number of cells in the bone marrow decreases as we age. So for example, a bone marrow of somebody who is 5 years old will look, for the most part, so if you look under what I'm showing as normal, and I have a little green circle there, we can see, let me see if I can show this here. We can see that some of these purplish areas, so those are the areas that are making blood. The white spaces here are sort of the resident fatty cells. And you would think, why is there fat cells? Is it because somebody is overweight? Well, that's actually not the case. So these are normal resident cells that are stromal cells. They support the bone marrow, and they serve there to essentially fill in the empty spaces. And so if somebody is, for example, 5 years old, all of this space in the bone marrow would be mostly of this purplish blue. So that's the stem cells and various progenitors. But if somebody is, let's say, 50 or 60, we would have something like this, what I'm showing here on the slide. And we have sort of a rule of thumb, we use 100 minus age. Okay, so if somebody is 50 years old, you would expect 50% of the bone marrow space to be occupied by this producing stem cells. And so if somebody is, for example, 70 years old, would be 30, and if somebody is 90 years old, it would be 10%. Now you can then imagine that a bone marrow biopsy that I'm showing here on the right side of the slide. Now, this here also shows areas. So the one in the red circle shows basically none of these stem cells. And then right next to it is a little focus, and it's a little patchy. And so you can imagine that in the case that somebody presents and their blood counts are very, very low, and the bone marrow is completely empty, it's relatively easy to make a diagnosis of aplastic anemia. If you present when your blood counts are moderately low and you still have little patches of the bone marrow that are compensating, you may end up with having slight reduction in the cells, or maybe even on average, it may be okay. It's just what's maybe is present is that you have many areas that are completely absent, and then you can have little patches. And so sometimes patients experience that they have a bone marrow biopsy that is obtained and it's non-diagnostic, meaning it looks okay. It doesn't look like aplastic anemia, but it surely, otherwise there's no other explanation. And then sometimes then the blood counts continue to progress, and the second biopsy then may show that, well, by now we have a lot more empty spaces. So this speaks to getting the right diagnosis and sometimes the value of repeating that biopsy. And so, of course, you would think, how do patients present? Patients are frequently previously healthy, and they may even have had very recent normal blood counts. And then suddenly, depending on the speed and the rate with which aplastic anemia symptoms develop, you may have sort of relatively incidental finding, meaning that it was just as Ellen mentioned in the story, that you went and the blood count was just found to be low initially, and you didn't even know you were ill. And then some patients really present to the emergency room because they're bleeding, and they may have a fever, bruises, heavy menstrual periods, bleeding gums, no energy. So this would be very typical. And then once we have this constellation of factors, we diagnose something called bone marrow failure. And it's a term that we use, for example, If you've heard somebody saying heart failure or kidney failure, liver failure, well, this is just non-specific term that describes a bone marrow that cannot do its job and produce blood cells for life. And it can be caused by for many different reasons, right? So here, there may be also a misconception in that the blood counts may be low. Bone marrow looks aplastic, meaning empty. It's just the synonym for empty. And then the key then is to still figure out why is this happening? And this may be part of frustration on the part of the patient and family when you're coming to the hospital and you're wondering, what is it that they're checking? Why is it taking so long? Why is the treatment not started? And so some of the reasons, for example, that can cause low blood counts and an empty bone marrow could be medications. So some of the key offenders, for example, may be medications that are given, let's say, for autoimmune diseases, for example, methotrexate, or seizure medications given for epilepsy, new antibiotic that may have been started, infections, various other diseases. For example, again, things like rheumatologic conditions like lupus. And sometimes bone marrow may not have enough building blocks like the B12 or iron. So all of this really has to be checked. And in the bone marrow biopsy, one of the key aspects would be to be sure that this is not early MDS. And it's sometimes really hard to figure out if this indeed is MDS or it isn't, because the number of cells that we are checking is relatively low. But after all of this, we may still not find any apparent cause. And then we end up with a situation where the most likely explanation is acquired aplastic anemia. And so here, what I mean when I say aplastic anemia, this would be this autoimmune disease, autoimmune aplastic anemia, as opposed to a congenital version of aplastic anemia due to bone marrow failure that's more common in pediatrics, but still can occur in young adults. And it's really important to also be sure that we're screening for this. The reason to check is, of course, because all of these are treated differently. And sometimes we may have to stop a medication that may, let's say a seizure medication or another medicine that may be contributing, and wait and see if the bone marrow recovers before we really begin treatment. Aplastic anemia is rare, and I think it's really a testament to AAMDS that we are educating patients, we are providing education for the physicians, we have a network of support for patients and families and doctors, and we are able to tell in which city would be the specialist, because otherwise it really may feel very, very lonely. So the statistics, and now, these are maybe outdated statistics, and are these really accurate? But 1 to 2 per million is what comes from epidemiologic studies. And then a little bit more, so maybe 4 per million would be in Asia. And it does seem that individuals of Asian ancestry are more likely to develop aplastic anemia. And there may be some genetic factors related to that. So typically, so this generally would be an estimated of about 600 to 900 newly diagnosed patients per year in the United States. And then these are spread out all over the country, right? And it can affect individuals of any age. So there are a couple of peaks and incidents, so individuals who are in their teens and young adults, and then also people who are older. And we don't really know why there's this prevalence differences. So what happens in aplastic anemia? I tried to draw a little cartoon to try to explain what I mean. But essentially, the idea would be that in the bone marrow, we have these stem cells, and then we have lymphocytes. So for whatever reason, these circulating immune cells in our blood decide to misfire, and they attack and destroy the bone marrow, leading to the absence of the blood cells to sustain blood production. The one difficult thing is that there's not a single one diagnostic test that can really tell you, like a litmus test, oh yes, this is autoimmune. So it really is still a diagnosis of exclusion. So this then explains why the diagnosis and beginning of treatment is such a journey. So typically, we have somebody in whom we are suspecting aplastic anemia. Then generally what should happen is the institution of just sort of supportive measures. So if somebody needs transfusions, this is the time to get transfusions. If somebody has really low white cell count, neutrophil count, they may need prophylactic antibiotics, for example, to prevent infections. And then the key is to seek a center where you have expertise in treating aplastic anemia, because some of these decisions can be really critical to how a person does. After this, there is sort of a period of about 2 to 4 weeks when a ton of blood tubes are being sent everywhere. We're excluding all of these causes in order to really say, yes, this is the right diagnosis. In some patients, we may shortcut this by finding, so we now have a very good understanding that finding these little PNH clones are is very helpful for the diagnosis that this is truly an autoimmune disease. So in some patients, a diagnosis can be made a little bit faster. We can be a little bit surer that we are on the right track when we find PNH. And there was a question also yesterday in one of the question and answer sessions about why is it that somebody was told that patients with aplastic anemia, when they have a PNH clone, seem to do better, or somebody said that they respond better. Well, one of the reasons is that the diagnosis is more likely correct, that this really indicates it's an autoimmune disease. And then there's also another different type of genetic abnormality now that we also search for, called 6-PLOH. And some of the patients who have this also really can be diagnosed much quicker. Now you would say, what triggers it? I get a lot of questions for what caused it. Did I do something? Is it a medication? Was it the flu? Was it the vaccine? In most patients, we really cannot tell definitively what it was. There's a couple of things that we do know. So there are certain patients who are more likely to develop aplastic anemia because of their genetic factors. So for example, these HLA, so this is what we use for tissue typing, these immune genes. And so some of these immune genes appear to be really tracking with aplastic anemia. There are other inflammatory or immune conditions, for example, this hepatitis, that's non-viral hepatitis. It's thought that the immune system cross-reacts with the liver at the same time as the bone marrow, and patients may develop both because it's the same exact immune attack. Other medications, so you may know that chloramphenicol, it was an old antibiotic, completely banned now because it was really linked, even like eye drops, was linked to very rare cases of aplastic anemia. Now it's not even used in veterinary medicine, so it's really, it's one of the associations. Pregnancy is thought to be another trigger, but really we don't fully know. So this is sort of an answer that in most people, we can really never truly say what caused it. It's possible maybe infection or I wouldn't say, again, vaccine, because we essentially really, even with COVID vaccines, for example, people were massively vaccinated. And yes, maybe there are some individual cases where patients said, oh, it was in proximity to the vaccine, but we haven't had a major epidemic of aplastic anemia to say that. And certainly many lives were saved with the vaccines. Now, how do we treat it? Well, first we have to know how severe is it, right? And so it's divided, it's been traditionally divided into moderate, severe, very severe. And this is really by the just the degree of blood count lowering. So, and even non-severe, what is used as non-severe in clinical trials, for example, may be quite severe on an individual level if somebody is needing transfusions, right? I would say, how is it not severe? But what we use essentially is at least 2 bloodlines have to be low. So for example, this neutrophil count has to be less than 500 and platelets less than 20. And then when it's very severe, the neutrophil count is really low, less than 200. So usually we group them, the severe and very severe, sort of one group that requires most aggressive therapy. And then for non-severe, we treat, it really depends. So I will just spend one slide mentioning that there are some patients who have this moderate or aplastic anemia that doesn't fully meet criteria. And if it's very mild, we can sometimes just follow it. As long as the blood counts are not plummeting and falling and they're safe, some patients may be observed. Now, if it's moderate, it may also progress, right? And in many patients, they start out with low, with just a little bit of a blood count lowering. And then at some point, the blood counts may truly plummet. And ideally, you would like to manage this before it gets too low. So it's managed with medicines typically. And then we would usually, sometimes it's managed with lower intensity treatment. So for example, cyclosporin, it may be managed with eltrombopag, something like this. And then when this, it's maybe on paper non-severe, but one of the blood lineages is really low, requiring transfusions, sometimes we manage it just the same way as severe aplastic anemia. So here it's really a wide range of treatment choices that's guided by how bad the blood counts are and just a discussion with the patient. Now, how do we treat severe aplastic anemia? So we generally use two main treatment approaches. So transplant approach or non-transplant immunosuppressive approach. And then I'll talk a little bit about what's on the horizon. And this is actually quite an exciting time in aplastic anemia about some of the new clinical trials. So talking about immunosuppression versus bone marrow transplant. In general, as I mentioned a little bit ago, there are two main problems that we have. We have the problem that we have the bad actors, these lymphocytes, and then we have a problem that we're missing stem cells. So both of these approaches, whether it's immunosuppression or bone marrow transplant, they're trying to address both arms of the issue. So first, we want to prevent the attack on the bone marrow. In immunosuppressive therapy, we do this with ATG and cyclosporin as our primary means of attack. And then bone marrow transplant, it's done with something called conditioning. So these are chemotherapy drugs, but they also include ATG, there may be radiation. So that's what's done to try to remove these bad actors. And then we still need to make stem cells. We don't have stem cells in the bone marrow. So here, in immunosuppressive approach, the main treatment here is just time. We need time to allow these stem cells to regrow, and it takes a long time. And then with the now approval of eltrombopag that we use, eltrombopag also serves as a growth factor, and it tries to promote the growth of the stem cells. So that's sort of how it works. And then we just wait and hope that the stem cells come back, and then they're healthy and they can sustain life for a long time. In bone marrow transplant, here we are replacing the stem cells with the donor stem cells. So I will show very briefly, this is sort of a traditional diagram, but I have some key parts about how the treatment decision is made and what is new. So in general, there are certain factors such as patient age, and traditionally it used to be now for decades, age of 40, this is changing. Also, availability of the bone marrow donor. Traditionally, this has been a matched sibling, so brother or sister, but again, this is also changing. And then treatment was guided in a way where we would have somebody who is a younger a pediatric patient or a young adult, so under the age of 40, who has a fully matched, HLA-matched donor sibling, they would be recommended a transplant. This is still the standard. And then now what is changing is whether older patients or patients who have other types of donors may also go to transplant first. But traditionally, and again, this would still be in general the case that we would proceed with immunosuppression in older patients and those who do not have a fully HLA identical donor. And the immunosuppressive therapy we now use, so we still use the horse ATG, we still do cyclosporin, and then now we use eltrombopag. And I put here some of the notes and the commentary that really transplant appears to be also safer, certainly safer than it used to be. And I'll show some data in older adults that we now have half-matched donors who are becoming increasingly used with some of the new transplant approaches and unrelated donors. And they're also coming down the pipeline other types of they're called thrombopoietin receptor agonists, or TPO-RA. So drugs in the class of eltrombopag that probably also have activity, and there are clinical trials investigating, and some have been published, showing that they do, for example, have activity in aplastic anemia also. It's just they're not yet FDA approved for this indication. So I'll briefly mention some of the practical aspects and just outcome statistics for bone marrow transplant. And you'll hear more from Dr. Olson's talk later today, where he will cover the spectrum from a pediatric to adult transplant. So this is a practical slide about what to expect with transplant. What is it like? So the way I discuss it is that it's about a year out of your life for the process. So we have to have a person who is healthy enough to receive a transplant. That would be the patient. We have to have a donor who is optimally matched, be it, let's say, matched sibling donor or unrelated donor or a half-matched donor. We also then, and the disease has to be bad enough to need a transplant. So somebody who has moderate aplastic anemia, the disease, you will see why not everybody gets a transplant, because there are risks and toxicities also with transplant. So a person would be admitted to the hospital. Some places do it as an outpatient with a lot of daily visits to the infusion clinic. At Penn, we do it as initial inpatient admission for about 4 weeks. We have this about a week of a period when patients receive chemotherapy. So these would be drugs that are immunosuppressive, and they also wipe out the bone marrow. And there's ATG, and there may be radiation that's a part of this. And then we have, at the end of that first week or 10 days, we have an infusion of the stem cells through the vein, just like a blood transfusion. And then we have this period of time when we wait, because the blood counts are low, and you may be feeling unwell, and there may be fevers, and you're being treated for infections, and we are waiting for something called engraftment. And then the blood counts come up. And at that point, about 4 weeks later, you're discharged from the hospital. And at that point, you also have a lot of medications you're still taking, and they're important medicines because the immune system is not working yet. So we have to be on medications to prevent fungal infections, maybe fungal viral infections, some types of other rare types of pneumonia. Some patients may still be having low blood counts and may need other medicines. We have also immunosuppression. So believe it or not, you may still be on cyclosporin or tacrolimus when you exit the hospital to prevent this graft versus host disease, which is basically the donor immune system from deciding that your body is foreign to it and deciding to sort of attack it. And in most cases, patients leave the hospital with rising blood counts, and they may not need transfusions after leaving the hospital. So this is one key difference from immunosuppression. So 4 weeks later, you have blood counts when you leave the hospital. And then over a period of time, so usually maybe about 6 months, we then start to taper immunosuppression. And we monitor for infections during this time. You may be coming weekly or at some very close intervals to see us in the clinic. And then you're starting to sort of feel a little bit more like yourself. Maybe by about 6 months, you're sort of feeling a little stronger. Maybe by the end of a year, people sort of start to feel like themselves. So it's sort of it's a journey to really recover and feel better. Off immunosuppressants, again, if all is okay, so certainly by about a year, you would expect you would be off immunosuppressants, and then we would start to revaccinate, because you imagine it's a new immune system. It's about sort of a 2-year process with vaccines. And then the goal at the end of this all is to be cured once and for all of aplastic anemia or MDS or PNH. So there are some complications that we always discuss, right? Why doesn't everybody just go get a transplant? Well, because it can be risky. And there could be allergic reactions. Your body may not like chemotherapy or radiation, side effects, toxicities, infections. Sometimes graft could be rejected. Fertility may be an issue in younger patients. And then the immune system may not function well for a long time. So it's sort of a potential risks. But at the end of this all, we just, take one step at a time. And if we know that this is the best course of action, I think, right, there has to be hope, and we're going to be moving forward, like Ellen said. So now, what are the statistics? How well do we do? What should we expect? And it's much better than before. So this is actually really hopeful. This is the most recent slide from the Center of International Blood and Marrow Transplant Research. It's free for everybody. Their documents are free for download. It's the biggest organization for bone marrow transplant. And you can see here, so I'm going to show, right? So it shows here numbers. So what are these numbers? And what are those numbers? Well, that's incredible. That's numbers of patients with severe aplastic anemia transplanted in the United States just between 2016 and 2021, right? So this is actually, it's big numbers. So it's the best data we have. And for us, so I'm not talking about pediatrics, but you can see just how well all of these do. This is matched related. This is sibling, unrelated donor. This is half matched donor. And this is mismatched, unrelated. They're all excellent. In adults, we still have some room to go. And now I'll show you, this is adults, all comers. So this is also including young adults in their 20s, right? Which is very different from someone who's getting it in their 60s. But we have for all comers, match-related donor, 3-year survival, 88%. Half-matched donor, 85%. And then worse with unrelated donors. However, this is now, so this was published, it's a summary from 2018, right? So 6 years ago, this was a study from the European Bone Marrow Transplant Network where they summarized, and their conclusion was that we need more progress in older adult patients. This was sort of their big conclusion, where they looked at people who were transplanted before 2009, and this was transplanted after 2010, and they basically showed that for patients who are between 40 to 50, actually the survival was worse. And the reasons for this were graft versus host disease. So we still have a lot of work to do. And as we get older, transplants are harder. So I don't want to sort of just say everybody get a transplant. For some patients, it may not be the right decision. What is clear, though, is that going to a center that transplants more patients, and this was from the same European, the European BMT study showed that the centers that transplant more than 3 patients per center, so you need a little volume to know what to do with patients who are immunosuppressed and have low blood counts. So don't do it at a local center that doesn't transplant aplastic patients. Go to a bigger center that has experience. Okay, now another one of the most interesting and very exciting developments is that we have now new approaches to transplant that bring access to transplant to people who previously couldn't find a match, right, in the unrelated registry, for example. So half-match transplants are becoming really a possibility. Also, new approaches allow us to use donors who are not fully matched. And there are some clinical trials that are ongoing that I'm going to highlight that look at bringing upfront transplant a little sooner. So for example, there's a transit trial, which is a randomized trial in pediatric patients, where patients are randomized to going to immunosuppressive therapy versus unrelated transplant as a first line of treatment. And then we have also another trial that's coming up also from the big transplant network called the Cure AA, sort of the name that inspires, shows sort of the inspiration, and the goal of this is to use upfront either haploidentical, so half-matched, or unrelated transplant, both in adult and some pediatric patients. Okay, that was the transplant piece. Now I'll talk about the non-transplant therapy, immunosuppressive therapy, 2024. This is a similar diagram to what I showed before. What is our journey when somebody is undergoing immunosuppressive therapy? So we also start here. So there is sort of an initial hospital stay for this to receive course ATG. It's about 7 days, 7 to 10 days, all give or take. We have cyclosporin that is started, and then we also start usually the Promacta, Eltrombopag. Following the hospital stay, people still leave with low blood counts. So the blood counts do not magically go up at the end. In fact, they are probably lower after ATG, and they may be a little bit, it will take a couple of weeks to get back up to their previous baseline. When you leave the hospital, you still have medications. And so the medications are designed to, of course, treat aplastic anemia. So cyclosporin, Altrombopag. There's going to be steroids, so prednisone to prevent serum sickness. It's a side effect of allergic reaction to ATG. And then there's a number of medicines to prevent infections. And there could be other medications like a supplement for magnesium, for example, or a blood pressure medication, something like that. So you sort of leave with the same probably number of medicines or similar to even what we talk about transplant. And you still need transfusions. And this will take about 3 months, sometimes 3 to 6 months. And I'll show you really the graphs for how quickly the blood counts come up from clinical trials in a second. And then eventually you will notice that you need fewer and fewer transfusions. Now, how long do the medications last? So generally, Altrombopag is used for about 6 months, give or take. Now, it all depends also on how the patient is responding and how the blood counts are doing. So, and usually if there's no other bad changes in the bone marrow and if the blood counts are still very low, we would typically continue it longer, as there's emerging data that using it for a little longer may allow for a more complete recovery of the bone marrow. Cyclosporin is continued for a long time. So it's sort of a maybe a 2-year journey if all goes well to taper off. Some patients cannot taper off and may need to be restarted on cyclosporin again. And then there may be relapses or things down the line. So it's a journey and there may be more treatment required. So some patients, I've received questions, can patients be cured with immunosuppression? Yes, but some patients relapse. So it's a disease where there are certainly patients who may not ever require further therapy and they have very good blood count recovery. But for a large group of patients, this may become sort of a lifelong part of their sort of changing perspective that this may be something that will require treatment in the future. There are some adverse effects too to immunosuppression. The main ones are, after this infusion, potential for infusion reactions and allergic reactions to ATG. The biggest thing that we discussed is infection risk and the fact that it just takes a long time to improve blood counts. And there's some uncertainty. Some patients do not respond to the first round of treatment. Other things that I will mention here briefly, but we could talk about it, is that, right, so the relapse risk is about 30%. And there's also a risk of something called clonal evolution. So this would be the risk of developing PNH, for example. And it's really hard to estimate what that is. Many patients, or maybe 50% of patients, have tiny amounts of cells called PNH clones. But some patients develop expanded clones and they require treatment for this PNH. And then some patients, so maybe about 10 to 15% of people may develop MDS or even leukemia. And so you heard a very moving and inspiring journey of Ellen earlier today, of her battle with this over time. So how do we respond? How well do these treatments work? Now, this here is a historical slide. This is from 2011, and this was before Promacta was done. So some of you in the room may have received treatment before Promacta was approved. So you were treated then with typically ATG and cyclosporin. And now this was before 2011. We didn't really know which type of ATG is the horse, right? So this may have been part of the clinical trials, the horse or the rapid. We know that now this ATG, this antibody that's made in the horse, is better. And so you can see here, for example, so what are the statistics where we have after 3 months in the top row, we have 62% of people, of patients treated with this, improve their blood counts. It doesn't mean improve to normal. It means blood counts are better, not requiring transfusions ideally. And then after 6 months here was 68%. So this is 2/3 of patients, right? This is not very encouraging numbers. But you could see that 5-year survival, despite all this, was okay. So this was from the trial, and we had about 90% of people were alive. They probably required further therapy. And you could see here at the bottom that this was, some of the patients went to transplant. right, if they were not responding, and those who responded did well. Now we have this new line of therapy called, we sometimes started referring to it as triple IST or triple immunosuppression, where we add a medication like eltrombopag. And here we can see that the response is much better. Before was 2/3, now it's 80%. And we can see here that at 3 months, so the response was 80%, complete response. So let's say platelets over 100, hemoglobin over 10, ANC over 1,000 was 30%. So this was a big improvement. This was really sort of a game changer. And then after 6 months, again, it was even better response. And you can see just this was the timeline of how quickly do the blood counts rise. And it doesn't give us really week by week statistics, but it shows us just baseline 3 months, 6 months on trial. But you could see that at 3 months, many patients still had low platelet count. So the blue is the new treatment. In the red was just without the Promacta. So you could see it does take a long time. So, and before 3 months, if somebody is still requiring transfusions, this is normal. So, and does it really improve bone marrow? Yes, indeed. You could see from this clinical trial where we can see that at baseline, you see that bone marrow was fairly empty. Now, at 3 months, we can see, and so this is the graph showing the cellularity, you could see it improving, and it really was meaningful bone marrow recovery. So it is possible to recover bone marrow with immunosuppression and eltrombopag. One key piece here that was that came out also as another important data point is that cyclosporin is really essential for durability of this remission, right? So we think somebody, for example, improved initially in the clinical trial, they at first were stopping cyclosporin and Promacta all at 6 months, and they had almost half of the patients who relapsed if the cyclosporin was discontinued early. And then they amended this clinical trial, and they had cyclosporin continuing here for 24 months. And we still have, of course, the relapse rate. That's not insignificant, but it's much better. So what happened to patients who initially relapsed? Most of them responded to either adding cyclosporin, adding Promacta back. So most cases, we can rescue people who relapse. So in general, this was a cartoon from a commentary that we did on this, on the long-term outcomes in aplastic anemia, but it really shows you that I think initially, if you see that somebody is running away from the fire at diagnosis, everything is very acute, then we have this early response, we are celebrating at the top, then this person is coming down here, we are tapering cyclosporin, and then there may be a relapse. And so essentially, we have to reframe how we think of this. So this is sort of a journey, and we have to do better about relapses, and there may be other things down the curve that may happen, right? So for example, development of PNH or other things that may occur in patients. But overall, if we think about how do people do, so what matters, how long do we live, right? So we heard about such a dire prediction before, you have 6 months to live. We don't talk about like this anymore. This is just remarkable how far we've come, but you can see that now patients who are treated with immunosuppression and eltrombopag, now this first graph just looks at overall survival, and here we can see that patients do really well. So this is 4 or 5 years and 92 overall survival with this. So yes, people may relapse, but this relapse now, this is that second graph, and you see patients who relapsed in red and patients who did not relapse. So we can save people who relapse with treatment. So it's sort of a medical disease that we manage, and the relapses are generally life-altering, but not as life-threatening, and for the most part, because we monitor patients and we can resume medications quickly, and we can treat them with to prevent a bad outcome. Now we can also think, does it matter if my blood counts didn't return to perfectly normal? We don't know whether complete, just how full the response is, how well this is going to matter down the line, maybe 10 years down the line, or for clonal evolution that we talked about. But we do see that patients have complete response in green and partial response in blue as far as how long patients live. It really also having stable blood counts that may not reach the parameters of complete remission is also okay. However, if you don't respond, then as you can see, we are in trouble. So that would be the group of patients that we really have to do better at treating and finding salvage therapies for. And then finally, talking about evolution to MDS, for example, or development of these genetic changes that we are monitoring for with these bone marrow biopsies. So here, if we have somebody who doesn't have any new genetic changes, this is in blue. And then we have a curve here where there are genetic changes but are not classified as high risk. So this would be, for example, sometimes we have mutations or we have chromosomal changes that are not associated with bad prognosis in myelodysplastic syndrome. So these would be generally patients do okay. So these are not as impactful. It's the red line where people develop sort of high-risk clonal evolution. That again, this would be progression to MDS. So overall, I guess to sum up, we have still excellent responses with this. It's not in many people, this is not the cure of aplastic anemia in a sense that you will never need treatment for it. But even if you need treatment, generally people do really well. Okay, I have only 2 more slides left. So this is the penultimate slide. So what else can be used for treating aplastic anemia currently? So what other regimens you may have encountered or heard about from other patients? So some people are treated with low intensity regimens, whether because they are not healthy enough to receive ATG or because their disease is not bad enough to require the risk of ATG. And so sometimes treating, for example, with just cyclosporin and eltrombopag, or cyclosporin and another type of drug like eltrombopag, for example, romiplastim or other drugs that are in that class. Cyclosporin alone sometimes is used, or in patients who sort of relapsed or refractory or maybe older and for some reason cannot take cyclosporin, sometimes just eltrombopag alone has been used. Danazol, you may have heard, it's a hormonal medication. It can improve blood counts in some patients. And then other older regimens that sometimes are used, for example, alemtuzumab is something that is tried also. It's another type of immunosuppressive therapy. And there probably are several others that I'm not listing here. And so these generally are options for people in second or third line, or people who relapsed, or maybe people who are not strong enough to receive the high intensity treatments. Now, what's new on the horizon? It's actually an exciting time. So we now, coming from the time when we didn't know how to treat aplastic anemia, when ATG was in clinical trial, then we knew cyclosporin, then we finally added Promacta. Now we're discussing different drugs such as romiplastim, and now there are also novel immunosuppressants that are being explored. So there's a clinical trial at the NIH that is looking at inhibition of JAK. So it's basically JAK inhibitors. There are drugs that are approved now for other types of blood disorders that are being applied here. So the clinical trial is open. Currently, it's enrolling patients who are refractory or relapsed setting, so it's not for frontline. Also, there's some upfront trial, clinical trial that's open for anti-interferon gamma therapy, so it's another type of immunosuppressive approach. Also, new approaches to relapse prevention are being explored. We are now really expanding the number of options for example, of these growth factors like eltrombopag. Really a lot of progress. You will hear a lot more from Dr. Olson about new approaches to conditioning, graft, depleting T cells, for example, or this upfront haploidentical approaches. So this is really exciting, and also expanding it to different graft types and expanding access for, do we reserve the transplant for down the line? Do we shift it up front? So that's all I have. Thank you very much for listening, and open for questions.
Thank you very much for your presentation. I appreciate it greatly. You talked about coming home with the like additional medications besides the treating medications such as antifungal, antiviral, anti-infection, drugs. How long, if a person has been treated 2 years ago and let's say relapsed and initially was only taken off of the anti-infection bacterial drug, but still continues to take the antiviral and the antifungal medication along with cyclosporin and Promacta. How long do you keep a patient on those other drugs?
It's a great question. So I will tell you my general practice guidelines, but making a note that we don't have data from large numbers of aplastic patients after these regimens. So, but I'll tell you sort of what we do at Penn and also what the general infectious disease guidelines are. So for patients who are neutropenic, we have a risk of bacterial infection. So sometimes this is not universal, but sometimes you may be starting a prophylaxis with an antibiotic. If the patient is neutropenic for a very long time, then there's a risk of mold infection. So this is where it comes from, this antifungal. And then particularly when we have ATG and other drugs and even post-transplant, when your adaptive immune system, these lymphocytes are now pushed down by ATG and cyclosporin, then we really start with antiviral. So for example, acyclovir would be common to prevent shingles. And then sometimes, depending on the degree of just how low these lymphocytes are, we also borrow from experience in other settings to start, for example, on medication to prevent this pneumonia. Some people are started, for example, on atovaquone or dapsone or pentamidine. So some antibiotic to prevent this pneumonia and then the fungal. Now, how long? So if, for example, your lymphocyte count has improved and recovered, at some point after treatment, the risk with a normal lymphocyte count, now this is outside of a transplant setting, in somebody who is now far from ATG, a couple of months, and we look at the, let's say, absolute lymphocyte count, this could be one metric, it recovered, or this particular type of lymphocyte called the CD4 count sometimes is used as a proxy, borrowing from, let's say, HIV literature or transplant literature. So sometimes we use evidence to guide the decision and say, okay, at this point, we can stop this, let's say the pneumocystis prophylaxis for this pneumonia. We may start also the antifungal. Antiviral acyclovir is a little tricky. So it's relatively well tolerated by patients. And our immune system is such that even, let's say, a healthy older person, now this may be before the newer shingles vaccines can develop shingles. So in shingles is sort of an unpleasant side effect. So we sometimes have a discussion that if you are not having any problems with taking this antiviral until you're off of cyclosporin, I frequently keep a person on this, but it's sort of right. So the immediate danger period is very close to this ATG. So fungal viral infection, this would be the immediate danger period. After lymphocytes recovered a couple of months after, usually everything except for antiviral, if someone is not neutropenic, could potentially be stopped. But again, I don't want to say, go ahead and stop the medicines that your doctor put you on, because there may be very important reasons why you're on it.
Thank you.
Again, thank you so much for your presentation. Is there any evidence that people who are severely allergic and have a history of severe allergies are more prone to this aplastic anemia, since they're both autoimmune issues?
It's a great question, but there is no evidence and no reports of association with allergies. But there is a general sense, so it's sort of a sense in general in the community that there's an association with other autoimmune disorders. So for example, maybe a little bit of lupus or psoriasis, this would not, or autoimmune thyroiditis generally. So may occur. Allergies specifically, it's sort of, it's not so much so.
Thank you for your presentation. To expand on the last question, can you give a little more information about how other related autoimmune diseases are thought to perhaps trigger aplastic anemia?
So great question, and I can speculate, right? So we are learning a little bit more that all of us may carry increased predisposition to dysregulated immune system. So for example, normally we have our lymphocytes, right? The immune system is circulating through the body and looking for viruses or looking, for example, for new things that develop from cancer somewhere in the body to attack that. But something is preventing these lymphocytes from attacking normal tissues, and we call it immune tolerance. And there are some ways in which it's created. So we have an organ called thymus, and when it's right here, and when, actually right here, and when we have lymphocytes that are newly developing, they see what's being shown on the cell surface in the thymus, and they say, okay, if you attack that, you're dead. So those lymphocytes should be removed. Then there's another type of protection called peripheral tolerance. And there are some types of cells called T regulatory cells, T regulatory lymphocytes. And they're basically these lymphocytes that circle through the body and they prevent activation of our lymphocytes to our own cells. If something happens, so to break this tolerance, then autoimmunity can develop. And the thought may be that if you have, for example, some condition that means that your mechanisms to prevent this tolerance are imperfect, that the immune system can just fire and be activated, you're going to be more prone to developing different types of immune disorders. And there's some very well-known real diseases where this happens. So patients may have multiple full-blown autoimmune conditions. That's very rare. But sort of this, you know, my aunt had lupus, somebody had multiple sclerosis. That type of history is just in general relatively common. But we don't have a very clear linear line. We're going to be checking this gene, that condition. Right.
I just have two questions. One is when you were at the initial slide, we were talking about causes, right? And I noticed that one of the causes are these anti-seizure medications, which are now used a lot as antidepressant or, you know, mood regulators or whatever. Have they actually linked any particular meds to aplastic anemia?
So another excellent question. And it's sometimes very tricky because the terminology is very slippery here. So be imprecise. There are medications that can cause lowering of blood counts and bone marrow suppression and may look like aplastic anemia. So which is a little bit different than triggering true autoimmune aplastic anemia. So and seizure medications, and I have to check where exactly I had them listed on the slide, but they're known, there's some, if you look in the profile of side effects, one of the key side effects would be, for example, lowering white blood cell count in some patients. That's why people have to be monitored, blood counts, etc. And so the treatment for that generally is holding the medicine and allowing bone marrow to recover. But there are certain medicines that may trigger through autoimmune disease, maybe through this break in immune tolerance, we don't know. There's only one that is truly seems to be linked to aplastic anemia, and that was the drug that's been banned for decades, chloramphenicol, which really seems to have triggered, in most patients was fine, but then people who had taken it, there were multiple reports linking this to developing this profound fatal bone marrow aplasia that looked very similar. So was it really? Who knows, but it did behave like aplastic anemia.
And my second question is, why would someone who is receiving platelet transfusions require HLA matched placement
Great question.
transfusions?
So platelets are typically, so in many cases, we transfuse platelets that are not matched, for example, for blood type, and they're from other individuals, right, who may not be matching your HLA. And typically we expect, let's say, a bump in the platelet count. So let's say if the platelets were 5, you get transfused. In the ideal setting, right, we could be hopeful, let's say it's 30 or 40. But then over time, some people notice I'm getting transfused and the platelets are not bumping. Then, so for example, the next day you're checked and you're very low. So maybe you're at 9 or something, some minuscule bump, and you start wondering what's happening. And there are many reasons why platelets may not improve after platelet transfusions. So for example, if somebody, there are some reasons that are not immunologic and not HLA related. Could be infection, you're consuming platelets, you're bleeding, you're making a clot. So platelets could be being used up as you're pouring them in. Okay, and there's so few that they just go and form a clot. Other times, it may be that we, together inside of that platelet bag, we also may be transferring sometimes some of the white blood cells. And it may happen even though we do leukoreduced, right? We recommend that we remove some of these white blood cells from the bags, but they still sneak in. Or from pregnancy, for example, in women, or from bone marrow transplant if somebody had a transplant, or multiple transfusions before. People may have antibodies form almost like, like an allergy. So an antibody that is going to be clearing those platelets as soon as they get infused. And so the way we screen for this is first we take the blood count, put the platelet bag in. About half an hour later, we check the platelet count. Did it bump? If it didn't bump, it really suggests that, oh, something cleared it as soon as it got infused. And then we start checking for HLA antibodies. And then if we find HLA antibodies, and some people may have, let's say, 40% of HLA types, they have antibodies too, of like most common ones. And then it may be that we need to request specific donor so that those antibodies are not right. So that if they're matched to you, you're not going to form antibodies to your platelets.
Thank you very much. And one last question too is also, I noticed on your listing of causes, one is that nobody's really gone into is the nutritional aspect. And if I can ask you that, and thank you very much too, I'll give you that in advance.
Yeah, so for the nutritional aspects, it's sort of, it's not really aplastic anemia per se, but empty bone marrow. So this would be on the cause of why does somebody have low blood counts and they have reduced number of cells in the bone marrow. And one of the most classical things we search for example, B12 deficiency. And that may be due to either malabsorption or dietary issues, or maybe an autoimmune disease in the intestine. If the B12 is very low for a long time, it's like a building block. And we need the B12 in order to have healthy blood cells. So we then screen, and usually it's on one of the first things that even emergency room doctor, who are first meeting you, they know, right? We're going to screen for all of these transient causes. So by the time you end up with a hematologist, chances are they've checked your B12, they've checked your iron, they've checked the copper, they've screened you for anorexia, malnutrition, profound weight loss, something like this, celiac. Thank you very much.
Thank you, Dr. Babushok, for sharing your time and expertise with all of us today.